Sounds good. Okay, hi everyone. I think we're going to go ahead and get started. As most of you know, this is a virtual event for the annual Purple and Gold Day. This year, the money raised is going to go towards the Student Emergency Fund to help students in need during this pandemic. So any of you that are watching, you can go to WIU's homepage to find a way to donate. My name is Lindsay White, and I'm a faculty member with WIU School of Nursing. I've also had the pleasure of teaching each one of our panelists over the last several years. I do want to say that each and every one of our former graduates are currently working and keeping our healthcare system safe and stable during this unprecedented time, and we are extremely proud of them. I do want to say that during this panel, if anybody who's watching wants to submit a question for any of our panelists, there is a Q&A button, and you can submit questions that we will get to towards the end, hopefully if we have time. So what we're going to do today, we are fortunate enough to have alumni join us who have a unique role on the front lines of this pandemic. I'm going to let them introduce themselves and where they work and when they graduated and what they've been doing since WIU. So go ahead, guys.
Okay, I'll go first. My name's Taylor Crawford. I graduated in 2016, and I worked as a med-surg nurse for 3 years, and then I've been in ICU for the past 7 months.
My name is Kendra. I've been working in med-surg at a Chicago hospital for 3.5 years-ish now. I graduated in 2016 with Taylor. Med-surg, we focus on neuro and trauma, but currently we've been COVID for the past month. That's me.
Hi, my name's Marley. I graduated WIU in 16 with Taylor, Kendra, and Sam. I started off on a general cardiac floor. I worked ICU for 2 years, and now I'm floating at the hospital in Springfield. And usually my job consists of me basically walking in, and there's a sticky note of where I'm going for the day. But since COVID-19, they've created new floors for COVID-specific patients, and that's where I've been since.
Hi, I'm Courtney. I graduated in May 2018. I went home to Wichita, Kansas, worked for a year in medical ICU, and then moved to Chicago, and now I'm in a neuro ICU there. And my unit currently is half COVID, half neuro. So.
Let's see, Jake.
Sure. My name's Jacob Jingland. I am a 2010 and 2012 grad of WIU, biology in 2010 and then nursing 2012. After nursing school, I went to medical school in the suburbs, Downers Grove at Midwestern University. And then I went to Pontiac, Michigan for my residency, which I am about 2 months away from completing. So I've been in the emergency room during all this COVID as one of the resident doctors.
Ash, you want to introduce yourself?
Sure. I'm Ash Ticasola. I graduated in 2014, did some OB, did some PEDS ICU, went back and got my NP, and now I am in immediate care as an NP at North Shore, and we do COVID testing for our area.
Kailyn?
Hi, my name is Kailyn. I graduated in 2018 with Courtney. I currently work in Davenport, Iowa, and I spent my first year as a nurse on a medical pulmonary floor, and I've been in the ICU for about 10 months. We take medical, surgical, and cardiovascular patients, but we're currently doing mostly medical COVID right now.
And let's see, who's left? Sam. Sam.
Hi, I'm Sam. I am in the northwest suburbs of Chicago right now. I graduated in 2016 with Marley, Taylor, and Kendra. I'm still in the Chicago suburbs working in the same hospital I started out in. I'm in a step-down cardiac unit, which is one of the 2 designated COVID units now. We're kind of just evolving to try to figure out where to put people other than ICU. So similar to Marley, we've kind of just been adapting and the floors have been changing. So right now we're one of the 2 COVID units.
Okay, so guys, thank you all for being with us. It's great to see you guys. Question, what has been the biggest change in your role in work? I know some of you alluded to that a little bit, you know, that you're normally doing one thing, you know, a couple months ago, and now you're doing something completely different. So if you want to chime in there, we'll start with Kendra since I know she's at work right now.
And a lot of gunshot wounds, car accidents, trauma. So obviously all that's slowed down. Well, not so the gunshot wounds, but the electrosurgery slowed down. The gunshot wounds go to other floors. So we have about 7 or 8, maybe 9 units now that are COVID only. The hard part is going into the rooms where it could be, it takes so long just to get in. If it's like a patient not falling, but trying to get out of bed, you have to like put your stuff on first. Like that's always scary for me because my safety is my biggest concern for everyone, and you have to slow that down. It's hard because I like to get to know my patients, and I'm being told that I can only spend at max 15 minutes of it. We've had doctors that have been our COVID only doctors on our floor, and they've already come back positive for the COVID. It's hard. We're using our equipment all the time, like our special N95 masks aren't always working. You have to use them so many times a day. I guess it's different because watching your patient from afar and not getting to know them. I can't really think about anything else right now.
Anybody else want to chime in there?
I can chime in. I am a new nurse practitioner, so I literally got off of orientation the day that COVID struck. So North Shore kind of put me in a COVID-only testing site. So the only patients that we see are respiratory URI symptoms. And then I go in and do my exam, and then we do testing, and we just kind of sit and wait. But it's not what I was prepared for. We're doing all this orientation, looking at different patient populations and, different differentials, when really right now we're just like COVID, just COVID.
Ash, what do you do from there? Do you send them to a certain facility? Do you have short-term tests? So do you know that day if they are positive, or what do you do with them?
So any patient that we see, we do a full exam. If they have to qualify for testing, so they have to have some type of symptom, related. We'll do the test. It's about a 24-hour turnover time. That result goes in our pool, and then we respond to them accordingly. At the door, all patients are checked with a pulse ox to make sure that they are breathing adequately, and then we can triage emergency by those saturations. But for the most part, it's just a normal patient visit, and to treat them accordingly, whether it's just the URI symptoms or if it's, escalating into a pneumonia or whatnot.
Taylor, has anything changed in your role and work since this has started?
Yeah, I mean, a lot has changed. Like, they completely redid our doctor teams. So we alternate between the two different teams. Like our normal ICU teams, they take over 1 week and then it switches. And then just like Kendra said, they're trying to get us to restrict the time that we're spending in the rooms. But especially for me, like in ICU, they'll tell you just spend as little time as you can. And then like I'll get an admit and I'll be in the room for 3 hours because you can't avoid it. I don't know, there's a lot of changes. And then like we get patients from other floors. And so before it was anyone who they were testing, they sent to us if they met IMC or ICU status. We got COVID only PUIs or positive patients, and then we would send them out if they were negative. But we actually do have the rapid tests right now. So their turnaround time for us is like 3 hours. So right now we're pretty much only getting positive patients.
So Jake, you're kind of unique here, both in your role and your unit. So you're in an ER. Can you tell us kind of different things that you've been seeing and how things have changed in your area?
Sure. The biggest change, I think, is the volume has drastically dropped, and that's a pretty consistent thing across the country. Most ERs are seeing a lot less patients, but the patients we're seeing are a lot sicker. Luckily, I think in my ER, I think we're starting to see a little less of the really sick corona patients, so that's a good thing. But the ER I work in, we averaged about 100 patients per 24-hour period before corona, and now we're seeing between 35 and 40, which is just so much less that some of our nurses are getting laid off. Our hours are getting cut, so it's drastically different. When this started, we had big tents put out front because we thought this was going to be this massive influx. So I spent a few days in the tent doing the screening exams, but since then they've come down because we've just seen so much less of the non-corona. That doesn't mean we haven't been busy, because the corona patients are so sick, they're so time intensive, and our ICU at my hospital got full very quickly, to the point where we had to kind of establish a mini ICU in our ER. So some of our ICU patients, where we used to be able to get them upstairs, within a few hours, we're spending 24 to 48 hours in our ER instead while we waited for rooms.
Marley, what about you?
Yeah, sorry, I forgot to unmute. Yeah, so I kind of work not with Taylor, but within the same facility, and it changes all the time. I feel like the biggest change is the policies every single day. Like, we're figuring it out just like everybody else. Every day is something new. We weren't supposed to do something this day, and now we're doing it. So, and like Kendra said, she mentioned the distance we have with our patients. It's just a completely different ball game, something that we're not used to, especially as nurses. We're taught to, be with the patient. The patient is the whole, and it's hard to keep that time limit. And like Taylor said, especially whenever you're trying to limit your time, sometimes it turns into an hour and a half, 2 hours you've been in the room, and it gets difficult, and they get very lonely too, because there's no visitors, so that's hard. We've been utilizing a lot of like FaceTime and different things like that, and the machines we used to use for translating, we use those for the FaceTime now, so that's nice.
Courtney.
Something, I guess, that's changed. So my unit's the one that's half COVID, half are clean. side, so no COVIDs and just neuro patients. We've opened up other ICUs in the hospital, and so we've been using our nurses specifically from our ICU to staff that unit, so we've been short. And so on our clean side, we've had like med-surg floor nurses help us. One of our nurses will have like 3 to 4 patients, and then that med-surg nurse just does tasks that we ask them to help us with. It can be a little overbearing, especially if you've got a couple crashers, but everyone's been super supportive and helpful. It's just a lot of adapting to the staffing and these patients. So.
Yeah, I forgot to mention that too. We've been doing some team nursing just to kind of prepare if we need to. Like she said, like the lead nurse and then the tasker, just taking on more patients, but with 2 people.
We've been doing a lot of that as well. We've opened up a second step-down unit to keep all of our non-COVID patients there, just to keep them away from it so we don't accidentally infect them with that. And then we have cross-trained, I think, 100 ER, PACU, and OR nurses to do like our tasky ICU things, so we can take more patients if we need to, if we do get a surge of COVID patients, and they can come help us. So that's just, it's been different, but it's been working really well so far.
So kind of similar to everyone, it sounds like everyone's got little ICUs opening up all over their hospitals. That's kind of what we started doing. So I actually returned from maternity leave in the beginning of March, which is kind of when this all started for my hospital. So at that point, we had just like 1 or 2 PUIs, which is persons under investigation. I don't know if everyone knows that term. Meaning people were waiting for their test results to come back. So we just had like a couple of those trickling in here and there. And since then it's evolved to, so like I said before, my unit is like a step down cardiac. We get all of the surgical cardiac patients, but now it's kind of just, we're just getting whatever we can handle because our ICU is overflowing. So they're training us on new drips that we don't normally get, like pressors, and they're training us on vents next week for those that are willing to do it. A couple people aren't comfortable, so they're giving us that option to opt out of that training because we're not in ICU, but we are getting ICU patients just to kind of offset the overflow that's been happening in our ICU. Since March, we've had, a steady flow of patients coming in that are positive and also just under investigation. So it's just kind of been like Marley said, and it's just been day by day. You're just like waiting for policy changes and just waiting for, our next order, and just trying to adapt to what they're telling us to do, just because it's such a ever-changing situation. We're not seeing a slowdown in the patients that are coming in my area. We're daily getting an increase. So like I said, when I returned from maternity leave, we just had 1 or 2 in the hospital. Now on my unit alone, as of yesterday, we had about 25 positive cases. So, I mean, it's just kind of, you're just taking it day by day, waiting to see what they say, and just going from there and just being willing to adapt and take on new skills, which, for some of us is a good thing because we're willing to do that. So it's kind of, I guess, good professionally, developing and stuff. But it is really hard to not have family members there. I think that for me is the biggest thing. We have a lot of elderly patients who are confused and they don't understand, and it's really hard to watch them be alone. And I know, it's just for family members to not be there too and to get their calls and they just sound desperate for any information you can give them, and just giving what time you have to them on the phone is really, for me, the most important thing sometimes, because I know how desperate they must feel to not be there. So that's really hard. And like Kendra said, to have patients that are climbing out of bed and you have to just remind yourself, no, I have to stop and gown up and make sure I have everything on correctly before I run in there. Or even when we've had codes, it's a completely different ball game now. So it's just, everything's changing, and you kind of just have to take what's thrown at you and hope for the best and hope to keep your patients safe and yourself safe. And a lot of the things that we're doing now is trying to keep everybody out of the ICU because it's been overflowing. So that's where we're at.
Thank you, guys. Kendra, I'm going to start with you. What has been the most difficult thing for you professionally or personally, if you want to answer that, through this whole bit? I mean, it's been crazy for you guys on the inside, I know. So we just kind of want to get a glimpse from you guys.
Probably the most difficult professionally is having, well, first off, dealing with anxiety of, we cleared out, we have 34 beds on my floor, and we cleared off all of them and to open up as a COVID, and within 24 hours we were filled up with positive patients or under investigation. But for me, the most difficult thing is seeing so many patients coming up, and it's so sad to see the age that they're at or whatever condition they're at. And unfortunately, I think they're just up there until we give them pain relief, and just until their time is time, unfortunately. I've been seeing a lot more of DNRs come up, younger and younger. That's been difficult. Or seeing a lot of people in their 40s that I have to tell them to not talk on the phone or don't even eat because their oxygen status is dropping so alarmingly low that they can't even have their lunch. That's been hard to see. And then they're just scared because there's nothing else they can do. So that's been difficult to see. And then also it's I think it was Sam was mentioning about like the codes for our floor. We only have 2 rooms that are negative pressure that can handle the aerosol if we had to do intubation or anything like that. So we've been told that if we have codes on our floor, we can do compressions, but we can't do regular like CPR until we get them out of their room and down the hallway into the negative pressure room. That's when we can actually start our code. So that's difficult, and I hope, so far, knock on wood, I haven't had to deal with that, and I hope I never have to, because that's like precious time that we're losing. And personally, personally, I find it difficult just reminding myself, it's probably sounds silly, but reminding myself every morning that I have to bring a separate set of clothes so that I can change out of these clothes and change into there, then go home. And before I even say anything to my family, I'm like, don't even look at me. I'm running straight to the shower. I can't even say hi. Like that's been difficult. And like before all this hit and before we stopped our visitors and everything, we actually had a patient that infected like half of our floor. So we had 20 staff members out, and I was one of them to be out. So that was kind of difficult to deal with. And I'm feeling a lot better now, but that was really tough time for that. But it's just a whole, like everyone's thing, a different ball game, and the amount of emergencies and seeing how quickly people can crash who are young, that is just scary to me. And it's like, we can't do anything fast enough for them.
Taylor, professionally and personally, what's been the most difficult for you?
I would say professionally, kind of like Sam was saying with the family members, that's been a big thing for me, especially because we've had some really sick patients who, I mean, we've had to FaceTime family members while they're on the ventilator and stuff like that, which is hard to see because the family members can't communicate with them. They can just see them. And then another thing, I think just kind of professionally and personally that is scary is we've seen a lot of, not a lot, but we've seen people who have come up negative, and then the infectious disease doctors like put everything together and they're like, we think that they have it even though their tests were negative, and we test them again and it's negative, and then like on the 3rd test they end up being positive. So I don't know, I talked to an infectious disease doctor and she said the last she had read, the tests were like 65% specific. So I think that's kind of scary, and that gives me anxiety, especially I feel like the other floors on the hospital when I float to other ICUs are having a lot of anxiety with taking the patients from us and just in general, because I mean, we're retesting these people. We send someone out and tell them they're negative, and then we're shipping them back up to our unit 3 days later to retest them. So I think that's been one of the hardest things.
Ash, you want to chime in?
I mean, professionally, being a new nurse practitioner, kind of being tossed out there, it's not what you picture in your head, but you just got to roll with it. We have daily meetings at 7:30 a.m., Skype in, phone calls, because the policies change all the time. So it's just keeping up and keeping current and understanding the CDC and IDPH guidelines and stuff like that. Personally, I am one of those unfortunate ones that was supposed to be getting married in June. So that wedding's canceled until we kind of get through all this. So what are you going to do? At least we're healthy.
Sorry, Ash. That sucks. Jake, you want to chime in?
Sure. I think the hardest thing for me is that what we can do for these people has changed, and how we're allowed to do it. So, for example, our EMS, the whole county, has changed to a system of not intubating patients, even in cardiac arrest, not even providing ventilations for these patients. In some cases, not even putting masks on, like oxygen masks. They're only allowed to put it through the nose for their own safety. And I support and understand that, but that means that a lot of these patients have an even lower chance that they're going to be able to make it. And then when they get to us, we can do most of those things, but I mean, we can't put a nebulizer, for example. We cannot give a nebulized treatment in our ER because of the risk of the virus going everywhere. So just having to change what we're allowed to do, and in a lot of cases it's more limited than what we used to be able to do, is probably the hardest part. And then I also agree with what everybody else has said about the lack of visitors. These people are really, really sick. A lot of them are close to death, and they can't have anybody with them, and that's pretty tragic.
Marley.
Yeah, I really don't have a lot to add to what they said. I think everybody covered it. I mean, I think everything's new and it's difficult and it can be anxiety provoking, but yeah, I think it's hard, and you just got to do what you can, go with the flow and do your best.
Courtney, you have anything to add?
Yeah, just, I guess the workload of these patients is very high. So it just adds a lot of stress. I didn't even know I was stressed. And then one of my coworkers was like, how is everyone doing? And I was like, I think I might be stressed. I haven't been sleeping at all. And I didn't even realize that I don't know. But then personally, I live in Chicago now. My family lives in Kansas, and I had a trip to go home in May, but that's not going to happen anymore. So I just want to see my family. So hopefully soon this is all over, but it's going to take some time.
Kailyn.
Yeah, so we actually recently had a policy change in the ICU where we're no longer allowing family to come in and see actively dying patients. So we have to call the family and tell them, hey, we think this is it. We think your loved one's passing, and we're so sorry, but you cannot come in and see them. You cannot say your goodbyes. And that emotionally has been very difficult. Making that phone call is hard regardless, but now it's just even harder. So sorry. We actually had a code the night that came out, and none of us really knew what to do. So sorry. That's just been hard to deal with.
I cannot imagine, Kailyn. Thank you for sharing that. That's not something that any of us were prepared for, and not anything we can prepare you for in nursing school, can we? Sam, you have anything to add to that?
So, I mean, just professionally, I know I kind of talked about the family member thing a little bit, and just adding new skills and everything. I think the biggest thing is just the stress of just every shift you are using every single ounce of brain power you have and every single thing you've ever learned and just trying to apply it as much as you can and just think as hard as you can at all times. And you just come home just mentally exhausted because like I said, we've been overflowing quite a bit. So a lot of my patients that I see on my unit, we're doing what we can to keep them out of the ICU. I've been told twice that there have been times where I've had a patient that there's only one ventilator left in the hospital, and it's between, they'll tell me it's between you or another patient on this unit. So basically do everything you can to keep him off of it, because just trying to keep everybody out of the ICU is the hardest part, because I'm not an ICU nurse. And while I would love to do as much as I can to help all of them, because what they're seeing is crazy, there's only so much we can do on my unit. And then personally, I have a 4-month-old son at home. I didn't imagine his first couple months being like this, and just praying that if I bring something home to him, that everything is fine, and just hoping that he stays healthy. And just going to work, coming home is the best and worst part of my day, because I can't wait to see him, but I also am just like terrified to see him. So that's been kind of crazy, but we're healthy so far.
Well, guys, so I know I'm going to get to some of the questions that some of our participants have been asking, and then we'll end with maybe some advice that you guys have to everybody out there, since you guys are kind of insiders in this. I had a question from Dr. Nash. Dr. Nash wanted me to say hi to everybody. She's proud of you. She wants to know, what kind of treatments are you guys seeing for these patients? I know, like Jake, you were saying that nebulizers and things like that are not supposed to be used in the emergency room. I don't know, as far as your ICU patients, this is a virus, right? So I'm assuming you're not really getting to antibiotics unless they get into like bacterial pneumonia. But what kind of, are you doing like dopamine, those kind of things? Some questions from Dr. Nash for you.
Sure. We were using the hydroxychloroquine for a while. It is still technically on our list of meds. Some patients are getting that. Our infectious disease doctor is pretty involved with who gets it. But for the most part, we've kind of moved away from that. If there's any concern for another bacterial infection along with the coronavirus, we've been using doxycycline as our main antibiotic of choice at my facility, unless there's real bad concern. If they're like a nursing home patient or something like that, they may need something a little stronger. So that changes situationally, of course, but for the most part, doxy is our main antibiotic. Mostly it's just support the ventilator as needed. We've been trying to reduce the use of ventilators as much as possible. So we're tolerating oxygen levels lower and lower. If somebody can be on a mask, on a non-rebreather, and have a pulse ox of 85 and they're comfortable, we're leaving it at that instead of intubating them if we can help it. The other treatments, steroids kind of wax and wane, whether or not they're in favor changes day to day. And a lot of the treatment is like that right now. There's just so much unknown that we don't have a set best thing yet. We can give albuterol via old school inhaler to patients that can do that. And that's, we're using Levofed as our main vasopressor if we have to use one for the really sick patients.
Anybody else in the ICUs or anything, seeing anything different that you'd be surprised with?
Yeah, I'll jump in. We're using a lot of Flowland for our vented patients, and we found ways to like wire it so it just is like straight in the system and it's not really aerosolizing outside of the ventilator, which is good. And we're proning our patients for as long as they can tolerate if they need it. And then we're also putting a lot of our COVID positive patients on heparin drips to help reduce the little microclots that they are finding in there, and that's been working pretty well. And then we're also using a lot of doxy and some hydroxychloroquine for some patients, depending on what infectious disease thinks is best. But our infectious disease doctors and our pulmonary team meet every single day to discuss new best practices and what we need to change and what we can keep doing. And we get emails, I think all of you probably do, every single day, multiple times a day with new policy changes. So that's been fun to try and keep up with.
One of, if I can add like a treatment that I've seen at my hospital, is I've been seeing a lot of patients on ECMO, not in our adult surgical heart units. So even like young people, they'll be on ECMO, and then they've been coming to us afterwards. So I haven't seen them on the ECMO, but I've seen in their post-op, they're on a lot of our Gatchbrand drips, so it's the blood thinner drips. They'll be on IV steroids, and then when they go home, they go on a steroid pack, and then we have to meet on a blood thinner, whether that they will be on for a month or however it might need to be. So we've been bridging people from their IV medicine to be able to go on to their pills. So we've had a lot of people at my hospital being treated with ECMO as a way to combat coronavirus.
I just want to answer, I opened some of these questions. Someone said, how do you guys decide what patients get to you? When you have limited supplies, how do you decide? It kind of, in that situation that I was talking about previously, it kind of just went by who crashed first. So that's what I meant by we're just trying to, keep them as stable as possible for as long as you can. Some people, the crash is inevitable. We do everything we can. And then some people, respond really well to all these treatments. And then another question was, are you using CPAP instead of ventilators? So what we've been doing is BiPAP for some people to try to keep them away from the ventilator. And then also things like nubs, vapotherm, stuff like that. My hospital just started the antibody plasma transfusions. We're doing a study with Mayo that just started last week. We have one patient that has recovered and tested negative twice after receiving the plasma infusion. So that's really promising. It's really exciting. Kind of crazy, but it's really cool that they're doing that. So we're going to get more and more of those plasma infusion patients. And then we're not proning patients on my unit, but that is something that we're doing. So I think that's really cool. Those ICU nurses are doing awesome with stuff like that.
I'd just like to add to the CPAP question. My hospital's not using that. We're not allowed actually to use CPAP or BiPAP because of the risk of spread of the virus. So patients go from either a face mask, non-breather to intubation if they need it. A couple of my colleagues and I are actually actively working on a way to make a closed BiPAP system. So hopefully that works and maybe you'll see it in the news soon, but right now we're not doing it.
I have a message from Dr. Ethington. She wants to say hello to everyone. She wanted to tell all the panelists, thank you for participating. It's wonderful to see all of you. Please know that the School of Nursing is very proud of you. We had a question from Courtney Hickle. What are the requirements for the test? So some of you that are doing the test, either in outpatient or inpatient, what kind of requirements do you have?
So I'll just add to this. I don't know what everyone else has seen, but I will say in the beginning, it was a lot more specific. Everyone had to have like a certain set of symptoms and IDPH had to approve the testing, at least for us. And then now it's pretty much at the doctor's discretion. So usually if they have shortness of breath or a cough or a fever, they're getting tested. Or like I've had a few patients come in with altered mental status and they can't answer the questions or if they've had any exposures, so they test them.
I agree. It's similar for us too. We're testing as much as we can, as much as our tests will allow. And it's gone from no tests to test everyone, which is nice because it's not good for supplies because we have to gown up for all of them, but it's good because we're getting a better picture of who actually has it and who doesn't.
Sorry.
Go ahead.
Oh, no, go ahead. Go ahead,
Oh.
guys.
So I work in like a city community hospital, but I also work in a critical access ER part-time, and they both have COVID hotlines from 7 a.m. to 7 p.m. every day of the week. So most of if people call the ER asking for a test, we'll divert them to the hotline. But as far as our inpatients go, if we get someone in the ICU and they have a negative like nasopharyngeal swab, most of the time they're usually intubated by the time they get to us. So our pulmonologist will actually send a bronch specimen and they'll test them again because they don't necessarily trust the nasopharyngeal swabs.
I was just going to add that my hospital has implemented a policy that all admitted patients, regardless of their complaint, get swabbed. And we are lucky enough that I think about a week ago, we got the 15-minute turnaround swab. I'm not sure it's the greatest. I don't always trust the negatives, especially when I really, really think it's corona. But we're able to test pretty much anybody that comes in that we want to, and we are able to tell them fairly quickly. And so anybody that gets admitted gets it, and then anybody that we're going to be discharging that we actually think might have it, we test.
So tagging on to that, do you guys feel like there are enough tests in your areas? That you have enough testing supplies?
I mean, if I could talk for my area, I'm North Shore, so Northern Illinois, by Chicago. We have enough testing. We're testing, like that's our main goal right now is testing. So we've got 4 specific super sites and we're testing anybody with symptoms. We also have drive-through available for those with, lesser risk factors and more mild symptoms. Our tests are the 24-hour turnover. They're a little bit more sensitive than some of the other tests you guys have described, but it's like, can you wait 24 hours versus the EDs that get those 15 to 3 hours, so turnover times.
I think we have enough in Michigan at this point. We did not at first, for sure, and we were incredibly restricted when we first started, but I think we've got enough now in Southeast Michigan, in the Detroit area.
So we have several people who want to thank you for the work that you're doing. They say that you guys are heroes. We have somebody watching from Georgia who was asked by a special friend to watch. Thank you very much. And they're saying that this is very sobering. Thank you for what you're doing and how you're handling this, and they admire all of you. Professor Matagauda, she wants to say hello to you as well. She has a question. Does the BCG vaccine protect people from COVID-19? Any thoughts on that, or do you have any knowledge about that?
I haven't seen anything to that effect yet.
We've talked about it, but we don't have any data supporting it, but it's interesting the things that are coming out of the works right now.
Question for Jake. Is this crisis affecting your employment plans in July?
Not that I know about yet. I haven't heard anything from the hospital. I'm going to Lake Geneva, Wisconsin in July. And last I heard, my orientation is still supposed to start July 20th. Last I heard, my move is still going to happen as long as they let us cross the state border. So we'll see. But right now, everything's supposed to go through.
Kailyn and all, thank you for your compassion. Nurses truly are the lifeblood for the patients. Thank you for all that you are doing for our families. Question, how often do you get tested? And I don't know if that's patients, I'm assuming. Have any of you been tested? Is that a personal question?
I can go ahead and answer. I haven't been tested yet, but it's something I've been wanting to do because if I am positive and I do have those antibodies, I would love to donate plasma to help with the plasma trials because that's something that my facility is also doing with Mayo Clinic as well, and I would love to help be a part of that.
Along with that, I haven't been tested yet. I don't have any symptoms. The only test is we have symptoms, but Rush is now offering antibody testing to their employees. So got my appointment at 8 a.m. on Tuesday. I'll let you know. But hopefully I have them and I can hopefully use that to help people. I don't know. So we'll see.
And how often can your patients be tested? I know some of you were talking about your patients were tested 3 different times. Is there a certain span of days that you guys do that?
I haven't seen a specific span of days. It's mainly been if the infectious disease team is pushing for it, if they still think everything else has been ruled out and they think that that's what it is, then they'll push for it. And we have like a command center that it has to go through. But for the most part, if it's the specialist saying it needs to be retested, they allow it. I think one of the patients that got tested 3 times, it was probably 3 times within a week. And the 3rd one was positive on that patient.
So question from a soon-to-be nursing graduate, going to be graduating this May. Do you have any suggestions for new grads about how to prepare to start working under these conditions? Kind of a crazy time.
I think it all depends on where you plan on working. I know we are hiring a couple new people, and we are actually sending them out to our floors that are still med surge. So basically they're going to train on other floors, and when hopefully soon things go back to normal, then they'll come back to our floor. I would just say if you do end up having, like with your being on a COVID floor, things will be very different than your normal standards. Depending on where you're at, it'll be like I said, everything will just be different. So for us personally, they might, and depending on where you're going to go, they might send you to a different floor to train on, just so you can actually have the experience you can learn from. But I think it just depends on where you go.
So our unit is doing something similar. All of our new grads are either training on a different unit or just training and not being allowed to take care of COVID positive patients, just so that they can get, you know, the experience under their belt and everything like that. I have been a nurse since 2016, and I will say that there are times that I still feel like a new grad in this situation just because it's so new for everybody. None of us have ever dealt with a pandemic before. So for new grads, just do the best you can, rely on what you've learned, and just try to absorb as much as you can while you're there, because you're going to learn so much while you're out there anyway. So just know that you are doing the best you can, and, just have a really good support system if you can, if you're, fortunate enough to have people that you can talk to about it. Just let yourself be supported by others, your family, your friends, and stuff like that, because it's going to be challenging. And just, you're going to get through it and it's going to be fine, but it's going to be tough.
Yeah, so I'll add to that. First of all, congratulations, that's amazing. Sorry this is what you're walking into as your first year of nursing, but you're gonna learn a lot. I think at my facility, our designated learning unit was our medical floor, and that's turned into our COVID floor, so I don't know how that's gonna change. But I think my biggest piece of advice would just be flexible, be open to learning new things, ask questions if you have them. We're all learning as this goes, so you're not alone in this, and I think find comfort in that. We're all in it together, we're all trying to do our best, everybody's there for each other. So yeah, and just make sure you have a good support system.
I think we have time for a couple more questions. I do wanted to pass along Dr. Lino and Professor Whitehouse are also saying that they're thrilled to see you guys. They're so proud of you. Also, we have several people on here that are saying that they're pulling for you and how proud they are of you guys coming from the same modest university. So we're pretty proud of you guys. So another question is, do you feel like the precautions that you have at work are good, and could it be better? Basically, infection control.
So I'll say my unit has gotten a lot better since this has started. I think now we finally had time to get enough resources. We're thankfully not reusing the one same N95 mask for the rest of forever. We get a new one every week, which is helpful. And then we're also fortunate enough to have cappers, which are like the negative airflow bike helmets essentially, and they filter out the air for you, so you're not breathing in all the COVID air, which is super nice. And then we aren't using disposable gowns anymore. We have gowns that can be laundered for contact precaution patients, so that's been really, really helpful for us. So we have gotten better, so that's good. We're moving in the right direction. I don't think we're quite where we need to be just yet, but we are getting there.
Yeah, my hospital, I mean, they're pushing to improve, but I mean, when we walk in, we have the option to go grab a separate pair of scrubs to change into, so we don't have to take ours home, or we can leave those there, especially if they become soiled after taking care of a COVID patient. So that's pretty major. And then we've seen some things run out. We've had, new N95 masks, but they've been really good about, getting us fitted for those, and then like new gowns as well. Some of them don't breathe as well, so we come out a little sweaty, but they're always replacing and getting us new things. So I do feel very well protected.
Yeah, I know at our hospital, they just implemented testing, like when you come into the hospital for all of the employees. We get our temperature. There's a series of questions that they ask before you enter. I know for those of us who work on the PUI and the positive floors, we all change our scrubs. We all have PAPRs. Every room is negative pressure. So I've said before, I'm like, I feel safer on this floor than I do going to Walmart or going anywhere else. So I feel very grateful to have the protection.
So I think finishing up, guys, we want to get your thoughts on anything that you could tell the public right now from your stance from the inside looking out. Any advice that you could give us. I'll just let you guys jump in here, whoever wants to say anything.
I'd like to start with this one if you don't mind. I kind of talked about this briefly earlier, that our numbers are way down. And that is because people are so afraid of coronavirus that they don't want to come to the ER. In a lot of cases, that's probably okay. The sprained ankles and the sore throats, a lot of those can wait. But we're actually seeing a tragic number of people that are staying at home with heart attacks and strokes and things that we could have done something about, but instead our ambulances are finding these people at home dead, and that is really, really tragic. So my advice is, if you have chest pain or trouble breathing or weakness on one side of your body or trouble speaking or any of those types of alarming symptoms or anything that you're concerned about, things that 2 months ago you would have come to the emergency room for because you were afraid that something was wrong, you should come to the emergency room. You should call an ambulance. You should come to the emergency room. You should get the help that you need. It's better to have a small risk of being exposed to coronavirus than to die at home of a heart attack that you could have been saved from. And that being said, ERs, we're all doing our best to keep the people that we think have coronavirus separated from those that we don't think so. So if you come in and you're having the chest pain and you're not having the fevers, the cough, all that other stuff, we have areas of the ER that we have not been putting coronavirus patients in. So please, if you need help, go get it. And I was reminded recently that applies to mental health as well.
I agree with that 100%. I don't work in the ER, but I've heard some stories like that, and that was very well said. I just want to say a thank you really quick for all the support from the public. I literally drive to work with people like cheering out their windows, and family members who can't see the patient will cheer me on through the phone and be like, I'm so grateful for what you're doing. We have food constantly at work. Like, the support is overwhelming and it's beautiful. So I just love the positive attitudes and the support that we've been getting. So just a huge thank you to everyone.
Yeah, I'm gonna agree with that. The support has been awesome. It's so nice to, have people who understand and who get it. And I know that there are people out there that don't, but the people that do, it means the world, to even just see comments on Facebook and posts on Facebook, people that think similarly to you and get it and are going through something similar, because really we're all just trying to get by, and just to see that there are other people that are feeling the same way as you is nice, and just people that appreciate you. There's so many people that say, like, you guys are heroes and stuff like that, and we don't go to work feeling like that, and we don't go to work we don't leave work feeling like that. That's not something that, at least for me, I don't go like through my day thinking that. I'm just like, so overwhelmed throughout my shift that I don't have time to even think about stuff like that. So, just to be reminded that there are people who support us is nice. And we're just gonna, whether it's you or a family member or, someone that you know or love, like, we're gonna do our best to take care of you. And just, it's really nice.
Okay, guys, I think that's about it. We want to thank everybody for joining us. Thank you guys for taking the time out of your day to talk to us about what you're doing. And you know that you have our support. You have your alma mater's support. We are so proud of you. So we want to thank you. And I think that's about it.
Thank you for having us.